Let's give a round of applause for Dr. Lavik. Here you go, Doctor. Enjoy.
Thank you, Andrew. Great to be here, you guys. Let me just pull this up just a little bit. Okay. So I'm going to talk to you guys, as you know, about bone health and glycogen storage disease. Let me see if we can get this moving along here. Fix this. All right, I have no conflicts of interest, but happy Juneteenth, everyone. Yes, applause, applause. I mean, I think freedom, definitely. Okay, so our outline today, we're going to start in the classroom and then move into the clinic. So we'll start with a review of bone physiology. Always we'll go deep, drill deep down and come back up. And then we'll look at the factors that affect bone health and bone mineral density. Then we'll talk more about bone health in GSD and talk about the unique considerations. And we've already heard discussion so far today about different angles of the disease, depending on the disease subtype, that playing a special role in the condition. Then we'll sort of take ourselves into clinic, as I mentioned, talk about the evaluation of bone health, how we approach it. I am a pediatric endocrinologist by training, so I will approach it in the way we typically do. Then we'll talk about treatment options for GSD from a bone health standpoint. And then we'll finish up by bringing it all together with information about GSD across the lifespan with a focus on bone health. Okay, so like I said, let's start out. The human body in full has about 205 bones once we reach adulthood. But if we narrow that down and really focus in a little bit to a single bone, we can look here at the head of the femur to look at the two different types of bone we have within each bone. So there's cortical bone, which is the lamellar or that sort of laminated layers, the thick bony crust, and then deeper down we have the trabecular or cancellous bone, also known as the spongy bone, that provides a lot of the 3D structure and a lot of this sort of the strength we have in bone as well. And so if you go even deeper to say what does bone look like at the cellular level, we see that it's a combination of bone matrix, so connective tissue, as well as different cells that are there to maintain the bone and play a role in bone formation and bone resorption, and we'll get into those in a little bit. But looking more closely at bone matrix, it's a combination of collagen fibers with mineralization. Of course, we all think about calcium as being a major player in bone, but other factors involved are phosphorus as well as magnesium. And the bone matrix forms a 3D scaffold on which these minerals bind in order to form that full structure of the bone. And the minerals take a form of what we call hydroxyapatite crystals. So it's a combination of calcium, phosphorus, magnesium, and some other factors. You can almost think about it as like at its smallest form, we have these collagen fibers. Each of those collagen fibers is almost sugar-coated, except hydroxyapatite coated with minerals, and then those are all wrapped together. Each of those then are formed into a web, and then on top of that web and within, we have cells that are maintaining the bone. Outside of, sort of together with this, we also do have medullary areas within the bone, depending on the bone, that are involved with forming new blood cells in the bone marrow. So I'm not really getting into the blood marrow today. We're just talking about bone structure itself. Okay, so bone is dynamic. It's easy to say that throughout the lifetime. As you can see in these images, looking at an 8-month-old all the way up to an 18-year-old, you can see that, in infancy, our bones are made of a combination of cartilage and bone, and as time goes on, we see more and more bone mineralization, leading to less empty space, and certainly more structure and strength in the bones. And so in the middle image, you can see, if you look into the digit of the finger, you can see little lines and little openings, and those are the growth plates within each of the bones. And I always think about that as where the new bone almost forms up as magma, kind of rising from the ground and leading to spreading and strengthening of the bone and growth in children's. And then up into adulthood, that cement essentially dries. As we can think about it from that standpoint, the growth plates are closed and one has reached their final height. However, the bone strength continues to increase as time goes on, up to a point, and then we reach our peak bone mass in our 20s and 30s, and then as time goes on, our bone mineral density starts to decline with some age-related bone loss. So little kids, we have a sort of those toddler, preschool, school-age years, we have a rise in bone mineral density, both in males and females, a strong increase during the puberty years when estrogen and testosterone play an important role in strengthening bone. We have that time period in our 20s and 30s of attainment of our peak bone mass, sort of locking in as much bone strength as we can get, and then it starts to taper as time goes on. And certainly menopause plays a role in lowering bone mineral density. So when we think about bone being dynamic and bone changing throughout the lifespan, even when we reach adulthood and we have our bones sort of locked in solid form, it's still continually undergoing modifications. And it's said about every 10 years or so, our skeleton essentially is kind of changed out. So you can think about, I don't have any of the same bone that I did 10 years ago because over the course of those last 10 years, everything has been replaced by new bone. Of course, the structure is maintained. And so the cells that are playing a role in doing that are key players are the osteoblasts. Osteoblasts build new bone. And the osteoclasts, which are the cells that look sort of like the Pac-Man ghosts that are involved in breaking down the bone, kind of scrubbing it away, allowing the osteoblasts to come in and put in new bone. As you can see, in addition to that, sort of within the bone matrix, we have osteocytes, the red-pink cells, and they're sort of like the hermit gardeners, so to speak. They're kind of out there, spread out, maintaining the bone matrix and providing sources of support as needed. So to dig into this a little bit more, to talk about the bone remodeling process, we have within our bones about a long period of quiescence. If you take any section of bone or any bone surface in your body, and there is, after that period of sort of no change in growth, we reach an activation phase when we start to have new osteoclasts come into play. And as I said, they kind of come through and they're resorbing bone, so they're scrubbing bone, they're breaking down the, working their way through the connective tissue, kind of releasing the calcium, releasing the phosphorus. And then once they're finished with reducing bone, after it reaches down to a certain level, then macrophages come in and they play a role in kind of cleaning up, straightening the surface, allowing for the next phase, which is new bone formation, to occur. And that's when osteoblasts come in, lay down new bone, new osteoid, and that's the phase of new bone formation. And then subsequently, some of those osteoblasts place kind of differentiate into osteocytes and play a role in maintaining that bone, allowing for bone mineralization as time goes on. All right, so with this whole process going, as you guys can imagine, if you're at a construction site, It's never quiet. There's dust everywhere. There's always something moving and going on. And so we can think about the bone surface that's similar to that. With bone remodeling providing a reversible pool of calcium, phosphorus, and magnesium for the body, you can think about it as essentially like a bone bank. So even though the primary purpose of bones, of course, is to provide that tensile strength, we also can use it as a reversible pool of some of these elements that play a major role in other situations in the body. For instance, calcium is really important for muscle contraction, cell signaling, and maintaining other changes in the body, and so we really need to have that under good control. So how can the body remove and replace bone through this way? Well, if we're going to have a withdrawal from the bone bank, removing calcium, the way this is done is by sensing it from the parathyroid gland. So to take a step back, this process does require, just like if it's at your bank account, you're withdrawing from the bank account, that leaves a hole in the bank account, right? And so that you need that opportunity to fill that in again. And so when our blood calcium level is low, our parathyroid glands that sit in the front of our neck sense that decrease in the blood calcium level. Parathyroid hormone is released, and parathyroid hormone then signals to the osteoclast to start to break down bone, release calcium and phosphorus, allow that to be available for other uses in the body. And so in that process, as we said, that's important for maintaining calcium, but then that leads to low bone mineral density as a result. Or if that happens over time without any compensatory process, it's going to slowly weaken the bones. And so what parathyroid hormone does and what occurs is, in addition to that sort of emergency process to release calcium, it has two sort of longer pathways that it plays a role in order to increase calcium in the body. The first is by reabsorbing calcium from the kidneys. So we're having less calcium excreted in the urine. And the second way it functions is to activate vitamin D to allow us to absorb more calcium and phosphorus from our guts through nutrition. And so we'll talk a little bit more about this because we all hear about vitamin D, and it's such a key player in this process. So I want to devote a little bit of time to it. And so I think we all have heard, we all know that we can get vitamin D. We can make some of it our own from sunlight. Some states better than others. Now's a good time to be in Cleveland. And then on the converse, we can also get it from nutrition. So fatty fish, supplementation, other sources, we can get vitamin D from nutrition as well. And so through that combination, we're able to access vitamin D precursors. And so once those are available and in the bloodstream, the liver can modify those into vitamin D in its storage form. Technically, it's 25-hydroxyvitamin D. But that is the storage form of vitamin D, and it's the form we, as endocrinologists or providers, will check to say, what's your vitamin D level? And then once that, when parathyroid hormone is released, parathyroid hormone functions in the kidneys to fully activate vitamin D to its active form, which then functions in the intestines to absorb calcium and phosphorus. So like I said, when we're thinking about the bone bank, vitamin D is essential for being able to invest in it and really be able to increase our bone mineral density. And I always think about vitamin D as almost like the scoop. And even if we have good sources of calcium and phosphorus in our diet, if you don't have vitamin D, there's still no way to absorb it. So that's why, we're always thinking, well, what's your vitamin D? How is it, are you having dairy sources? Are we making sure that we're getting all the pieces together? Because if you don't have vitamin D, but you're still getting the calcium, you're still going to be behind. So when we're thinking about, as I said, we can withdraw from the bone, using parathyroid hormone is a sort of a short loop to increase calcium for the body, but in order to really be able to increase bone mineral density, the long-term process and sort of the net process of activating parathyroid hormone is to increase calcium reabsorption from the kidneys and then allow us to absorb more from the gut. So taking a bit of a shift, so now we kind of have that context. There are a lot of other factors that can affect bone mineral density. And so really thinking about bone, as we've talked about, at all levels, at each layer, we can think about what may enhance or decrease bone mineral density. And so the first aspect we could think about is the instruction manual, the genetics. Are our bodies appropriately making the collagen, and do we have appropriately functioning osteocytes and other bone cells to really help to optimize that? And if not, there could be a genetic sort of primary disorder of bone. Second is those nutritional sources that we've already discussed, making sure that we can optimize those. A third that we haven't talked about yet is physical activity. And really, every motion that we're doing, all weight-bearing activity is kind of pulling and stimulating the bones and allowing the cells within the bones to optimize the way the bone matrix is formed and really to strengthen those bones. And so a key factor from that standpoint. Other things outside of those would be the different hormones that play a role in bones, whether it's thyroid gland, growth hormone, puberty hormones, especially estrogen and testosterone, play a key role in increasing bone mineral density. Other things to think about is what other aspects of our health, and what are we ingesting, such as medications that may be decreasing our bone mineral density. Key players would be glucocorticoids or steroids that are very commonly used for inflammatory processes, but prednisone, dexamethasone over time can decrease bone mineral density. Other factors at play medication-wise would be antacids, which may decrease our ability to absorb calcium. Diuretics that are important from a blood pressure management standpoint, but may reduce the amount of calcium we can reabsorb from the kidneys. And then chemotherapies that may have a varied effect depending on the tool that's being used. And then, of course, when we're thinking about a person from a bone health standpoint, what other medical conditions are at play? As I already mentioned, inflammatory processes can play a role in bone health. Whether it's a systemic process, could slow the balance of bone formation versus bone resorption, leading to decrease in bone mineral density. Whether someone has a GI illness such as celiac disease, where they have decreased decreased absorption of the minerals that can decrease our ability to maintain bone health. As Dr. Krishnan already mentioned, thinking about the liver is really key, and we'll get into that here soon for GSD. Similarly, kidney disease is going to affect that bone health process, as well as any malignancy that may be occurring that can have a role, in different systems. So again, to sort of talk about the topic of this weekend, glycogen storage diseases, how can GSD affect bone health? I think we can all come at this from different angles, whether we're a provider, an ally, a person with GSD, or a family member, to say, okay, looking at this, what aspects of our lives are affected? Some of the key things that we can see are that, depending on the flavor of GSD one may have, the liver, the kidney, the muscle may all be affected to different degrees. And, these are all such important organs for optimizing bone health that we can think within each GSD as how each is affected and how we can optimize and how best to take care of it. And so calcium and vitamin D absorption or activation may be affected in GSD. Certainly physical activity and finding that balance between maintaining blood glucose, but allowing us to have sufficient physical activity to optimize bone health and bone strength is key in GSD as well. And so what we've seen over time in GSD is, there really is a sort of a dearth of literature about sort of bone mineral density in different GSDs, and the primary work that has been done, as with a lot, as we've seen already today, will be GSD1 with some work in GSD3 as well. But overall, it shows that bone mineral density in individuals with GSD is lower than those who do not have the condition. And so that can go from, pediatrics, lower bone mineral density as children, usually a decreased peak bone mass, and then, sort of lessen the bone bank, and as time goes on, bone mineral density may decrease and sort of stay lower from that standpoint. And I'll highlight a couple of key studies that, some of the larger studies that have reviewed this. The first is from Dr. Weinstein's group from 2013, and that team looked at bone mineral density in GSD type 1A and 1B, and so they kind of broke it down into those two subtypes. And so in GSD 1A, that study had 42 patients with a wide age range from 10 to 54. And so at baseline, 54 or about 55% of them, had low bone mineral density. So kind of less than two standard deviations or more, I should say, below average. And so when the team looked a little bit more closely to say, okay, can we see what else is associated with that, they found that individuals with GSD that had lower bone density by comparison were those that seemed to also have higher disease complications, as well as lower vitamin D. And so there were, within the group, on average, the vitamin D level was, I think, total, at least for those with higher vitamin D and lower, stronger bone mineral density, the vitamin D level was around the 20s, which is still below target, but it's in the intermediate range. Whereas those with low bone mineral density, that subpopulation did have vitamin Ds below 20, which is considered vitamin D deficiency. And then in GSD type 1B, the population was smaller, 12 patients, again aged 10 to 40, but they found that 2/3 of them had low bone mineral density at the time of the study. All right, and then the other, I think another key study, this one was from 2024. I believe this came out of Sweden, if I'm not incorrect. Looking again at GSD type 1, this work looked 2 time points and was looking both at sort of clinical factors as well as taking cells into the lab and looking at cellular factors, and using a slightly smaller population, 20 patients, younger patients with GSD1, age 3 to 20, they found very similar data that about 60% at baseline had low bone mineral density, and that percentage was maintained about 2 years later on reassessment. And what they found is that the individuals with higher bone mineral density scores actually also had higher muscle strength. So again, a protective factor of having more physical activity, more muscle strength with protecting bone. When they looked at the cellular level, there were no clear differences from what they could assess in osteoclast function in GSD compared to individuals without GSD, which suggests, there's probably not a sort of inherent biological difference. It's probably just everything that comes with the disorder and the condition that leads to the lower bone mineral density. That said, they did find that there was an increase in sort of the number of osteoclasts or number of those cells that break down bones in individuals with GSD and lower bone mineral density. So it suggested that maybe there actually is some factor, whether it's sort of inherent or secondary to the process. All right, so we're going to shift away from the lecture halls here for a little bit and then move our way into the clinic to talk a little bit more about how are we going to evaluate for bone health. And so many of us as patients have experienced this or will. Of course, like anything in the medical field, we always start with taking a good history. And so history is key in this case, of course. We're going to want to know, what is your GSD history to start with? And when were you diagnosed? And what has your care journey looked like? What medications have you been taking? And what complications have you had? What has been your sort of metabolic management? Though I know that that is an elusive term, as we heard recently in the previous hour. Of course, we're also going to want to think beyond GSD and say, well, what is your medical history? And what could be contributing? What's your dietary history? Are you a person that has dairy, or can you not? And then if so, what other supplementation maybe have you taken over time? And then past and current medications. Do you have a history of needing prednisone or other steroid medications that we know can affect bone health? And then for those who are old enough, what is your reproductive history? Have you gone through puberty? And are you making estrogen or testosterone? And then really focusing in on bone, what is your fracture history? Have you broken bones? And if so, what bones? And how old were you when you broke those bones? And what was the mechanism? Were you just unlucky and had too many falls off the monkey bars? Or were these a fall off the couch when you were young? Or a trip on a step? What was the mechanism? Kind of how traumatic was it? And also, do you have any spine problems or back pain that could suggest vertebral compression fractures? So with that history as our foundation, we would then move forward into imaging to look at bone mineral density. And of course, our gold standard would be to use a DEXA scan or a dual energy X-ray absorptiometry. And with this technology, we can focus in and measure the density of the bone at different areas. Classically, we'll look at the total body, we'll look at the lumbar spine, we'll look at the head of the femur or the neck of the femur, and we can look at some other areas as well, and then compare each individual compared to sort of the standard population. And as you can see up in the upper right corner, we get a readout of an individual's bone mineral density compared to the reference range. And so in this case, the individual has a normal bone mineral density, though it is a bit sort of below the mean. But when we talk about low bone density, I'm talking about people that would be in the white, kind of below all of that. So when we think about individuals with GSD, 60%, 55 to 60% are going to be in the low bone density range. In addition to DEXA scanning, we'll be looking at or considering spine films to look at the vertebral bodies to see if there are any signs of compression. On the left side, you can see a normal lumbar spine. The more like marshmallows stacked on top of each other it looks, the healthier you are, okay? Should be a little bit of space in between, but as you can see, those are holding their shape quite well compared to the side on the right with the blue shade where you can start to see that compression. We're getting some squishing going on, and clearly with the arrow sign, you can see where there is a vertebral compression fracture. And then in addition to history and imaging, we'll be, of course, exploring from a biochemical standpoint, what do the labs look like? What is your calcium level? What is your phosphorus? What is your parathyroid hormone level? And that'll tell us sort of, looking at all of those together will tell us what is the balance of your bone health system. We'll often look at both the storage form and the active form of vitamin D, again, to see how these are playing out in real time. We'll want to know liver function, kidney function. We'll often be looking at the release of calcium, or sort of the excretion of calcium and phosphorus through the kidneys as well in the urine, since we can use that as a readout of how much calcium your body has, how much excess it may be having, how much it is sort of expending from the body. Of course, depending on the age of the person, we may include other labs as well, like estrogen, testosterone, other puberty hormones. We'll want to be sure that thyroid function is normalized, since thyroid hormone plays an important role in maintaining bone health too. Again, like thyroid hormone, we want to check the growth factors, make sure that those are at optimal capacity. And then, depending on the individual, we'll be exploring other possibilities, such as other inflammatory markers, concerns for celiac disease, hematologic possibilities, or other mineral deficiencies, such as vitamin C. So kind of taking all that into context, let's say that we've sort of identified an individual, we've kind of walked through the history, let's say, a 19-year-old female, we've gotten that GSD history, we've performed a DEXA scan, and what we can see in this case is she has low bone mineral density in the neck of the femur. You can see that her orange mark for her falls just outside that -2 standard deviations. And we look at her total bone mineral density, total body, we can see that it's a low as well. And so then, okay, so this is an individual who has reached adulthood. Kind of what options do we have? What can we do at this point? And so let's segue into treatment and treatment options that we have. The first, of course, is going to be prevention, or supporting the current state and really trying to optimize that state. So making sure there's adequate nutrition, adequate supplementation, calcium, vitamin D, really optimizing physical activity as we can to kind of maintain where we are and increase it if at all possible. Optimal metabolic management, again, it's hard to pin down what exactly that is, but the prior studies did refer to elevated triglyceride levels as being non-consistent with optimal management. So really trying to find those ways to, and I think it was well described to say, really what we mean by that is looking for improvement. So, where did you start from, and how can we keep moving the needle a little bit more? And then any other potential causes of low bone mineral density, what other modifiable causes can we mitigate? And then, other healthy practices, minimizing smoking, vaping, tobacco, excess alcohol, all of these things are going to play a role as well. And so, in children with low bone mineral density, if we got a DEXA scan in a 12-year-old, we may not necessarily need to move on to bigger guns, so to speak, than just these supportive measures, because we know that they have bone growth ahead of them, and they may be able to, we can sort of see where we are and monitor over time, optimize what we can, and then ride the wave as they go through puberty, knowing that their bone mineral density is going to increase, and seeing kind of what their trajectory will show. However, if it's clear that bone mineral density is concerningly below the norm, and especially if there are fractures occurring, we may move forward into therapeutic options. Bisphosphonate therapies is often the first line we see and we use in many individuals. In adults, we often will use oral bisphosphonates, alendronate, that can be taken once daily or once weekly. In children, if we're using a bisphosphonate, we often use an intravenous zoledronic acid that can be given once every 6 to 12 months. All bisphosphonate therapies play a role in sort of capping bone. They're considered anti-resorptive, so they're blocking the osteoclast from functioning. And the way they do that is they sort of interdigitate into those hydroxyapatite crystals and sort of cap off the bones so the osteoclast can't sort of get in there and pull them apart. I almost think about it as like bisphosphonates are planting landmines in the bone, so the osteoclasts can't really get in there and do their thing. If we can often use those over time to sort of cap the bone and then use them, monitor bone mineral density and adjust as needed. However, if we see that is not able to maintain bone mineral density, we can't necessarily increase bone mineral density just from the bisphosphonate therapy standpoint. So in adults, we can use parathyroid hormone analogs, which, just as they sound, they're recombinant forms of parathyroid hormone that can be given subcutaneously and provide all the same supports and that net positive support that parathyroid hormone can for bones. So yes, there is sort of that short-term probably resorption, but the net change of reabsorbing calcium from the kidneys as well as absorbing phosphorus and calcium from the gut is a sort of a net positive process for bone health, increasing bone mineral density. And those we consider anabolic medications. And there are some other medications that are sort of in the pipeline and in early phases in supporting bone health that, I think the future is bright to say what's in the arsenal that can be used to increase bone mineral density. All right, so I'm coming to the conclusion here today. And we've walked through, a brief, quick summary of bone physiology, thinking both from the structural level as well as the cellular level and the mineral level about bones. And we've talked about what is affected in GSD. And it is sort of flavor specific, so to speak, whether the liver is affected, the kidneys, the muscles. But I think some of the key features that are shared and kind of is that bone mineral density is decreased from the data we have in glycogen storage diseases compared to those without glycogen storage diseases. But there are opportunities we have to really optimize bone health throughout the lifespan. Key factors would be optimizing nutrition. So really, and by that I mean striving for sufficient calcium, sufficient vitamin D, supplementation when needed, and working with your providers to really make sure that your tanks are full from that standpoint, sort of as a baseline. And then in addition to that, trying to hit that strong point from a metabolic management standpoint to say, if we can keep this, we're going to be able to optimize as best we can for supporting our bone health. A third key factor, as I mentioned, was sort of trying to optimize muscle mass and muscle strength, knowing that is going to optimize our bone strength as well. And keeping that all in mind as we manage the other aspects of glycogen storage diseases. Of course, other aspects that are helpful throughout the lifespan would be other healthy lifestyle habits, maintaining the other hormones in a normal range, minimizing bone weakening medications. But then, as time goes on, if we're measuring bone mineral density in our individuals with glycogen storage diseases, if and when do we need to step in and use medications in order to optimize bone health? And I think that's going to be a discussion for each individual and their care team. But we do have, in addition to the baseline supplementation, we have options as far as the bisphosphonates and the parathyroid analogs. And I think the future is bright as far as the opportunities we have, and as life is prolonged, we get to see how what opportunities we have for new care. So I'll go ahead and I'll stop there. But I appreciate everyone for your attention. And then I have a list of some key references as well as some further reading. But you guys are all, I believe that a copy of these slides will go out to all attendees after the fact. But again, I'm happy to take any questions, and thank you very much.
Got one right here. Hi, Katie Larsenodi, pediatric endocrinologist at the University of Iowa. I was wondering if you have any thoughts on ketones and low bone density?
So I think it's a great question. You know, trying to find ways to optimize that metabolic picture can be quite a challenge. And so, you know, I think that every patient's a little bit different, but trying to find our opportunities to really, you know, minimize the ketosis, but at the same time, keep it all in balance. So not the best answer for a really hard question, I have to say. But
Hi, Scott. I'm the grandfather of a 2.5-year-old and 8.5-month. So when would you recommend a DEXA scan to get a baseline to see what's happening from at least a starting point for a young child?
yeah, I think that's, you know, it can be a bit of a moving target, and it really starts with a history. Getting a sense of the fracture history in children. In those without glycogen storage diseases, we often will use a DEXA once someone's had more than one sort of low trauma fracture. And so if someone is functioning well and able to be active and not having, you know, no signs of a fragility fracture, we may not need to dig deep, so to speak, you know, and we can do a lot of prevention just by optimizing the factors we know about in order to really maintain that. But I don't believe there are any specific guidelines in GSD as far as bone health management and really when to start doing that. But I think, you know, around the probably the late preteen years into the teen years, I think it's an important conversation to have. And then we also know that we're going to be going into that period of bone accrual during puberty that it's going to enhance bone mineral density for everybody. Great question.
Thank you.
Hi, it's Radhe. My daughter has GSD 1A. She's 26 years old. Just wondering, contraception medications and bone density are the relation, what extra precautions we have to take?
Yeah, you know, we know that estrogen plays such an important role in bone health, and I think making sure that the regimen she's using allows her to have estrogen exposure. And so I think that, you know, there's so many different options available, and that each person could make a decision with their healthcare provider.
Hi, thank you for being here and all the information. My granddaughter is 5. She has GSD 11, which is Fanconi-Bickel. Does she have a greater chance with that of having low bone density and shorter stature as she gets older?
So I'm not aware of any specific studies that have been done with GSD 11.
Okay.
I'm not sure if other experts in the audience have experience from that standpoint, but sorry, I can't be more helpful.
That's okay, thanks.
Hi, you talked about 2 types of vitamin D. I take vitamin D. I am Joan. I have glycogen storage disease 15, and I take vitamin D3. Is that both of them?
So great question. So that's fine. So vitamin D3 and vitamin D2 are both forms of vitamin D. They can both be used by the body. The D2 and D3 are more specific for whether they came from plant sources or animal sources, but the body is able, I mean, in broad strokes, the body is able to use both of those. And so when I'm talking about sort of active or inactive forms of vitamin D, that's speaking to sort of what the body is doing for it. But as far as supplementation, vitamin D3 is just fine, as is 2.
Collagen peptides are all the rage now. Is that anything that's good supplementation for bone density?
So I don't have a lot of expertise in in that area, but I'm always a little hesitant of things that are all the rage. But, yeah.
Hello, my name is Fabiola Reynoso. I'm a type 3A. And I made a note right now. I've had almost 8 bone breakages throughout my life. I'm like, oh, yeah, I broke it here. And the last one was pretty severe. It was 4 bones.
Oh,
just
wow.
a simple trip and they found out I have osteoporosis. So I know that the guidelines, I believe it's 2 to 3 years for the Dexcom, but for a GSD patient, is it okay to have it sooner? Because last year they put me on something called Evenity, which is probably like the newest I heard, but it gave me horrible side effects, the headaches. So then they put an intravenous, I think it's called Reclast, once a year. And I haven't had the headache, so that's good. But I want to know how my bones are doing if I can't have a Dexcom until, another 2 years or 3?
Yeah, and so as a pediatric provider, I can't comment as fully from an adult perspective, but often we can use the DEXA scans as sort of a proxy for fracture risk, but we can't, it provides us that information, and so that we know you're receiving the therapy, we can expect that it's improving things. I think that every 2 years or so for a DEXA scan, but if you're having the therapy, we can expect that there's going to be an improvement. Yes.
All right, 2 things. David, are you going to be talking about the estrogen? Okay. Okay. Well, one thing is just, I'll start with that. There's always concern with estrogen in terms of increasing adenomas.
Okay.
And so we have to be very careful in terms of, and this comes up in terms of, do you not get your period? Do you need estrogen? So are you missing something that you're replacing or giving exogenous extra? It's a very big topic in GSD in terms of increasing adenoma risk. Just like if you're pregnant, your own hormones are increasing risk and potential growth of adenomas. So there's often progesterone alone kind of contraceptives are recommended.
Okay.
And I'll let you add on to that if you want. But
I appreciate that
and
context.
so it's just a different population in terms of the estrogen has such a significant effect for risk for adenomas and hepatocellular carcinoma. In terms of the older studies, I wouldn't think they did height adjustment, but in terms of DEX as an interpretation in GSD, just like in so many other rare diseases, short stature is associated with the process of GSD in many patients. And so as you know, the DEXs are falsely low if you don't account for stature. And so as Karen Lochner, endocrine pediatrics in Connecticut. Sorry about that. But so we always do height adjusted using the CHOP calculator, et cetera. So there's a calculator to adjust for height. If it's valid for adults is unclear in any condition, but in terms of before you would treat someone, do you usually do height adjusted and use height adjustments to see if it's really low bone density or not? I mean, that's all the stuff I think has to be mapped out for GSD because it hasn't been.
No, I think it's a great comment and great point. I think
but in your clinic, do you do the height adjustments to help determine if this really is?
Typically we will, and so I think that, it's important we keep that context, make sure that we're being sort of adjusting as close to the mean as we can. Question?
Okay, I have a few different questions, but they should be quick. First, do you have any kid-friendly explanations for bone health support? I have a son who has GSD 2, and he has a stander, so he knows that that's important, but most of the time he just thinks we're torturing him. So is there anything out there to make it more, less clinical vocabulary for an explanation of why that's so important?
Yeah, I mean,
That
I
was a
guess
long question.
what you mean, just the difficulties with why do I need to be in a stander?
Why is this bone health piece so important for you? Why is it important to strengthen your bones for a GSD patient? is there kid-friendly versions of that?
I guess,
To help.
looks like we have some comments from the group here on that one.
Oh,
Yeah.
oh, I have other questions.
I'm a physical therapist, so I use standards all the time. So I think my first thought about that is to make sure that it's comfortable, because I wouldn't want to stand in something if it's causing discomfort. So we shouldn't be expecting people to put up with stuff that's not comfortable. And then also I don't know of anything in writing, but I think how old is your son? 12. Oh yeah. Right. No one the adults don't know anything and all that, yeah, no. But so I would actually just talk to him and on a one-on-one and try to do it more individually. I could look at giving you some sources. I mean, he's 12. He would understand some stuff that, yeah, okay.
Yes.
I love this. This is great.
When Andrew was going through, sorry, Andrew?
Mhm.
Andrew.
Yep.
Okay. So when Andrew was going through the talk about how the bones get built and everything, it's like a 3D printer. So if you have a good 3D printer, it'll build up your bones. But if you're lacking the right minerals in that 3D printer, you won't get good bones. That, I think, is a good analogy.
Okay, the other question is, we're in a pretty rural place. So as far as we were low on calcium, and their best suggestion, we're in Montana, and
Okay.
we're like way behind medically. Just saying. But their best suggestion was to have him eat Tums daily. But your antacids, there was something in your slides about antacids causing
True.
problems.
I mean, I think Tums is a really good way it's calcium carbonate, so it's a good
Okay.
way to get that as a source. But I was going to suggest Amazon too, but I don't
Okay.
know.
I
I don't know
just
if the
ha-
drones
is
are getting
there-
there yet.
Is there a best way to advocate for yourselves in a place that's not as familiar with rare diseases when it comes to stuff like that?
Yeah, I think that, I was going to say that the barriers are broken down so far with the internet age that, world experts are a few clicks away. And so if there are ways to expand your network, whether it's through one of the team members here or elsewhere, to really try to say, hey, can we flex out, and to say, who else can we reach out to?
Okay.
Just thinking along the 3D printer analogy, which I love, would be, finding a way to say, hey, you can't print 3D without getting the calcium in. So if you're having trouble with your son with taking the supplements, there's nothing he's going to be able to print. You can't make that any stronger if he's not taking the supplementation.
Okay.
But you're okay to go even with the antacid side point.
Okay.
It's usually more of those like proton pump inhibitors, the ones that are really limiting the acidity of the gut and the stomach, that are playing a bigger role in limiting absorption.
Okay. And then the DEXA scan for peds, can that be done annually, or do they prefer to, especially for like a wheelchair user who's not getting regular weight bearing like that?
I think every 2 should be
Okay.
useful at that point.
My last question is about contractures. Is that more of a muscle thing, or is that also bone? What's the impact of contractures on bone health?
So I would say, it's more of a muscle piece, but I wouldn't necessarily be detrimental to bone. It is sort of inherently causing a force, increasing force within the bone, or sort of from one bone to the next. But yeah.
Thank you.
Mm-hmm.
Unfortunately, we have to wrap it there because it is almost time for the next session to start in about 2 or 3 minutes. So if you would
Thanks,
all
everyone.
do me a favor and make your way to those. Yes, please give them a nice big round of applause. Thank you very much for your talk. And if you would